Asthma. Etiology. Asthma is defined as reversible airway obstruction associated with airway inflammation and bronchial hyperresponsiveness. The hyperresponsiveness of the airways is caused by a variety of local stimuli including histamine, leukotrienes, and prostaglandins. This produces the reversible airflow obstruction that leads to the characteristic symptoms of shortness of breath, chest tightness, and wheeze. Risk factors include 1. Genetic predisposition. 2. Family or personal history of atopy. 3. Maternal smoking and ethnicity. 4. Socioeconomic status. The role of other factors such as diet and pollution, black smoke, fine particulate matter, ozone, and sulfates, remains controversial. While not directly linked to an increased prevalence of the disease, they certainly exacerbate asthmatic symptoms and there is increased asthma mortality in areas of high industrial pollution. Other precipitants of asthma attacks include house dust mites, pollens, molds, fungi, cat and dog dander, aspirin and NSAIDs in sensitive patients, approximately 10–20%, and occupational exposure. Epidemiology. The prevalence of asthma continues to rise worldwide, particularly in developed countries. Approximately 15% of the adult population in the UK have asthma and, despite effective medication, there are still approximately 1,500 deaths from the disease each year. This continued morbidity and mortality highlights the importance of education for both patients and their doctors, with emphasis on adequate treatment regimens, good compliance, and rapid access to medical help when deterioration occurs. NB. Patients are at particular risk of dying from asthma if they are taking more than 3 classes of drugs, have required hospital admission in the last year, have psychosocial problems, have ever had life-threatening asthma. Clinical presentation. Severe acute attacks, acute breathlessness and wheeze, also hypoxia and or carbon dioxide retention can lead to stupor and or confusion. Chronic asthma, shortness of breath, wheeze, and a chronic cough, particularly at night when associated with a disturbed sleep pattern. Symptoms may be produced by exposure to cold air or exercise. NB. An isolated dry cough is perhaps the most overlooked symptom of mild asthma, especially in children. Particularly after colds and flu, patients may be left with an annoying dry cough and are frequently referred to specialists for further investigation. Bronchial hyperresponsiveness is often the cause and response to a course of low-dose inhaled steroids. Patients should be warned, however, that their symptoms may persist or return with a subsequent cold or chest infection. Physical signs. Life-threatening asthma. Peak flow 33% of predicted or personal best. Silent chest. Cyanosis. Altered level of consciousness, confusion, or even coma. Exhaustion and inability to speak. Hypotension or bradycardia. Severe acute attack. Peak flow 50% of predicted or personal best. Tachycardia. Increased respiratory rate, 25/minute. Patient cannot complete sentences in one breath. Use of accessory muscles of respiration and intercostal recession, especially children. Increased pulse rate, greater than 110 bpm. Moderate. Peak flow 50–70% of predicted or personal best. Wheeze. Dyspnea. Chest tightness. NB. The British guidelines on asthma management are invaluable, but remember that the patient in front of you is an individual. If you are worried in any way about someone with asthma, especially at night, admit him or her. This is particularly the case for those who have an attack that has been going on for some time. If they live alone, do not have a telephone or would find it difficult to return to hospital. Do not feel pressurized by the patient, nursing staff, or the hospital's bed state to send them home. Investigations. NB. Measure arterial blood gases if the patient presents with life-threatening signs or the SO2 is less than 94%. Blood gas markers for life-threatening asthma are normal or high PaCO2, normal range 4.5 to 6.0 kPa/35, 35 mmHg. Low pH. Severe hypoxia despite oxygen treatment, PaO2 8 kPa/60 mmHg. Chest radiograph. In outpatients, a CXR helps exclude other causes of wheeze, such as infiltrates resulting from eosinophilia or fibrosis. For patients presenting acutely, a pneumothorax should be excluded and evidence of infection looked for. Peak flow. This can be used diagnostically to look for morning dips. Motivated chronic asthmatics can also monitor their progress at home. In patients who clearly do not take measurements on a daily basis, make sure they know their best peak flow and encourage them to at least monitor when they get coughs or a cold. All patients should be given a management plan based on deterioration of their peak flow. Credit card-sized self-management plans are produced by the National Asthma Campaign, Fig 16. Lung function tests. These should be performed before and after bronchodilator, e.g. salbutamol. They are not helpful acutely, but are important as a diagnostic tool to look for evidence of reversibility and to monitor chronic asthmatics. Allergy testing. Skin prick tests can help identify allergens that may precipitate asthma attacks, although in practice many of these are not easily avoided. Differential diagnosis. This includes chronic obstructive pulmonary disease, congestive heart failure, upper airway obstruction, i.e. foreign body tumor, pneumothorax, bronchiectasis, pulmonary eosinophilia, Wegener's granulomatosis, and Churg, Strauss syndrome. Treatment. This section is for people with newly diagnosed asthma or asthma that is uncontrolled on their current treatment. Where the recommendations represent a change from traditional clinical practice, people whose asthma is well controlled on their current treatment should not have their treatment changed purely to follow this guidance. Offer a short-acting beta-2 agonist, SABA, as reliever therapy to adults, aged 17 and over, with newly diagnosed asthma. For adults, aged 17 and over, with asthma who have infrequent, short-lived wheeze and normal lung function, consider treatment with SABA reliever therapy alone. Offer a low dose of an ICS as the first-line maintenance therapy to adults, aged 17 and over, with symptoms at presentation that clearly indicate the need for maintenance therapy, for example, asthma-related symptoms 3 times a week or more, or causing waking at night, or asthma that is uncontrolled with a SABA alone. If asthma is uncontrolled in adults, aged 17 and over, on a low dose of ICS as maintenance therapy, offer a leukotriene receptor antagonist, LTRA, in addition to the ICS and review the response to treatment in 4 to 8 weeks. If asthma is uncontrolled in adults, aged 17 and over, on a low dose of ICS and an LTRA as maintenance therapy, offer a long-acting beta-2 agonist, LABA, in combination with the ICS, and review LTRA treatment as follows. Discuss with the person whether or not to continue LTRA treatment. Take into account the degree of response to LTRA treatment. If asthma is uncontrolled in adults, aged 17 and over, on a low dose of ICS and a LABA, with or without an LTRA, as maintenance therapy, offer to change the person's ICS and LABA maintenance therapy to a MART regimen with a low-maintenance ICS dose. If asthma is uncontrolled in adults, aged 17 and over, on a MART regimen with a low-maintenance ICS dose, with or without an LTRA, consider increasing the ICS to a moderate maintenance dose, either continuing on a MART regimen or changing to a fixed dose of an ICS and a LABA, with a SABA as a reliever therapy. If asthma is uncontrolled in adults, aged 17 and over, on a moderate maintenance ICS dose with a LABA, either as MART or a fixed dose regimen, with or without an LTRA, consider increasing the ICS to a high maintenance dose. This should only be offered as part of a fixed dose regimen, with a SABA used as a reliever therapy, or a trial of an additional drug, for example, a long-acting muscarinic receptor antagonist or theophylline, or seeking advice from a healthcare professional with expertise in asthma.